here, the anterior tangential, the anterior BFTA, the pachymetry map, and the posterior BFTA. This anterior BFTA is very close related with the total corneal coma, and the posterior BFTA I presently call the Supreme Court, because the asymmetry in this map will discard many corneas. The ninth map will be the coma. This is a typical case that you cannot see with other devices only because the scales. This is a perfectly anterior surface with the anterior tangential here. But when you see the posterior axial and the posterior tangential, you perfectly see that this is symmetric ectasic posterior surface. Okay, are you going to do surgery in this? Only if you see the anterior surface, but immediately you see the posterior, you probably will say no. And please observe here that all the keratoconus indices coming from the anterior surface are perfectly normal. And this is elevation topography, okay, because if I would be able to take out this name in the back, in the bottom, we are going to see something here, because this is best fit sphere here, perfect to see the Freydeck pattern here, or the peak of the mountain with the maximum best fit sphere, but the best fit toric-aspheric maps are perfect to see the asymmetry. If you take the delta between the minimum or more negative value here and the more positive value here, this is what means the Kranemann-Arce index or the AAI index. So best fit sphere elevation topography is used to study toricity and protrusion. And the Galilei has its numbers. The normal values are below 500 microns, green stips. The best fit sphere abnormal for the anterior surface will be 10-12 microns, and for the posterior abnormal will be 15-16 microns. If you remember the numbers Dr. Sinjab told us, the anterior abnormal is around more than 7 microns, and the posterior more than 16-18 microns. So the Belin-Ambrosio display, which is an artifact to increase the value of the best fit sphere, has a cutoff value very similar to the regular best fit sphere from the Galilei. The best fit toric-aspheric elevation maps, in the other hand, has to be used to study the asymmetry of the corneal surfaces. And what we are going to see is the delta between the minimum and the maximum point, not the maximum value only. As we showed that in Paris and in 2010 already, this number is directly related with the total corneal coma. So I taught this since 2009, 2010. However, this began to be known more after 2013, when this paper won the best paper of Journal of Refractive Surgery. David Desmaja and the group from Cleveland Clinic of Ron Kruger showed that the best isolated index to detect frustrated keratoconus was the index I call in 2010 Kranemann-Arce, and they call it AAI, or aspheric asymmetric index. And with this sensitivity and this specificity, which is very, very high. This comes from the work in Cleveland Clinic. Which one is first, best fit sphere or best fit toric-aspheric? And actually, we know that the best fit toric-aspheric is better than the best fit sphere to detect frustrated keratoconus. And which one is better, anterior or posterior best fit toric-aspheric? We know now that the posterior is better and more sensitive and specificity to detect frustre keratoconus. However, there is more coming. With the combination of curvature, axial and tangential, best fit sphere, anterior and posterior, and pachymetry, it was possible to create a new index called Cone Location and Magnitude Index X, CLMI-X. And this CLMI-X was proved in three serial cases. One in Colombia, the original, in Switzerland, and in United States. And you can see that if in Colombia, the discrimination was 100% between normal suspects and keratoconus, in Switzerland was 199%, by Dr. Koch in the United States is 98, 97%, and 100%. So the possibility to discriminate keratoconus and normal corneas presently is not a problem. The problem is to distinguish suspects or patients who are at risk of ectasia. And also, the Galilei will show you the Santiago PTA report is percentage tissue altered that will give you the risk of ectasia is presently one of the most sensitive indices to describe that corneas that cannot go for LASIK. Galilei also has dual Scheinflug tomography, and this is to avoid the parallax effects of imaging. Galilei shows you the data aligned to first Purkinje and pupil, not to the apex. It's the best of both worlds because it can perfectly locate all the optical scans, and with this, Galilei is able to give you the kappa distance. As far as I understand, the Pentagon is not able to give you the kappa because the kappa is the distance between the pupil center and the first Purkinje, not between the apex and the pupil center. It's the first Purkinje and the pupil center. So we presently know that if we have more than 0.45 millimeters of kappa distance, we don't implant diffractive multifocal IOLs. We are preparing for publication this paper showing that the astigmatism changes. 5% of normal corneas will change the axis more than 10 degrees if you align the data to the pupil center or to the first Purkinje. So, and we also have now strategies to improve the toric IOL calculation with the Galilei. And we always ask, should we implant premium IOLs in cornea with asymmetric or irregular surfaces? No. So we should avoid toric IOLs when the coma, total corneal coma, is more than 0.5 microns. What is the aberrometry the cataract surgeon needs? The total corneal aberrometry. So if we have this kind of cornea, normal cornea, with a spherical aberration between 0 and 0.03, we can implant any kind of IOL. The standard spherical, the aspheric neutral, or the aspheric negative. Okay, but if we have this kind of cornea already with myopic surgery, we cannot implant the spherical IOL because it has a positive spherical aberration. On the other hand, if we have this kind of corneas, hyperprolate corneas with negative spherical aberration, we cannot implant this kind of IOLs. So this is only possible with a device that can give you all this data. We also have an adapted double K formula for IOL calculations using the total corneal power. And Galilei finally has optical biometry, where we can see the length thickness, the CCT, the AQD, the ACT, the axial length, and it has an IOL calculator. The biometry is very accurate, and there are already papers compared the axial lens with the IOL master and the length star, and the IOL power also. And the Galilei is linked to the new generation of ray tracing IOL formulas like the Oculix and the Olsen formula. You can see here the position of the IOL. So this is now a new generation, possible new generation of formula when we can make a linear regression with the effective lens position. So several images we have now. This is an ICL in the cornea, the Arce in the anterior chamber, sulcoflex, piggyback IOL, toric IOL, complication like dislocated IOL, intracorneal segments that we are going to talk this afternoon. There is a special software for camera, for corneal inlays. We in Brazil have to prove to the insurance company that we have the disease, so I send this image, and now they approve immediately the JAK laser, the capsulotomy with JAK laser. We have digital goniometry and goniography, and we have the possibility to decide if we do for clear lens extraction or for JAK iridectomy. We also use the Scheimpflug images to help us after the cross-linking. We don't see the demarcation line, but we see the depth of the cross-linking effect. And Galilei finally is decided to work with femtocataract. Okay, Galilei has all this and much more. I'm sorry, it's priceless. It's all in one. Thank you very much.